a survey. Oh.
Yeah, we have some questions. Yeah, two surveys maybe you have seen in the Twitter.
No?
You haven't seen, so you're gonna see here. And it is 10 now. It's time. I will open the session.
Okay.
Miguel probably will come soon.
I'm here. I'm already here.
Hi, Miguel, welcome.
Nice, welcome.
Yeah, I
Thank you.
shared the screen. I didn't see you. Okay, welcome. Nice to see you again.
Sure.
So I'm opening. Good evening, everyone. Welcome to the EHS Journal Club tonight. Alexios and I will manage the session. This month's article is an evidence map and synthesis review with meta-analysis on the risk of incision hernia in colorectal surgery with standard closure. This article was published in Hernia Journal recently. Our esteemed authors, Cesare, Sara, and Miguel, they joined us. They are available now with us. They are our guests tonight. At the beginning, Cesare will make a brief presentation of the article, and Miguel will speak on the initiative behind it. Then we're going to ask the questions. This meeting will also be broadcasted live on our YouTube channel. You can also follow from there now, and the recorded event can be watched again in our YouTube channel. Yes, Cesare, the mic is yours.
Thank you. Thank you, Hakan. Thank you, Alexios. I have to firstly thank you for the opportunity to present our paper here. It's a work, it's a big effort we've done in last year, helped by COVID because it's difficult to review so many papers. I have to thank also EHS because it's always near to us and permitting us to listen to papers, and not our papers maybe so interesting, but a lot of papers have been pulled out by you and are very nice, and this evening are also very useful for us, for younger surgeons. So I will stop immediately and go to the point. Can I share the screen for a little? Okay. You have already presented the co-authors. There are other surgeons that could not be here: Friedrich Berrevoet, Diego Cuccurullo, Karel Decaestecker, Mariangela Dajko, Lisa Rossi, who worked with us. I have to thank Miguel Angel Garcia-Urena because this work comes from an idea of him directly in, I think it was September 2019, before the drama came out of COVID, and we decided to work all together. He launched this idea, this reason behind the paper, which is pop surgeon. He wrote a paper on behalf of the group. He gathered a lot of surgeons, and I think that he deserves the podium in this moment to show us and tell us what is this project that has gave birth to our paper. Please, Miguel.
Open the micro. Thank you so much for giving me the opportunity to be here. I have also prepared a few slides, Cesare, so you stop sharing, I can try to say mine. There are solo just such a few of them. And I would like, again, thanks the European Hernia Society for this great initiative. I think that we should be doing things like that. You know, it's something that join us and in our discussion. So it's great to have this kind of initiative to talk about interesting papers. And Hakan, of course, that is leading this this kind of media, no, communication to have this idea, and this is what we want to communicate. This was an initiative because we know that in the last 20 to 30 years, we have been improving our surgical treatment on incisional hernia, and we have worked a lot trying to reduce surgical morbidity and to avoid recurrence with better meshes, with better access, laparoscopic, robotic, probably optimizing the patient for the surgery, but instead of going to the right of the slide, would be better to come here and try to start from the very beginning with the opportunity to avoid the development of incisional hernia. So it's true that we know that as general or digestive or colorectal surgeons, we know that we use midline laparotomies or maybe pararectal laparotomies, but you know that there are another lot of specialties involved in this midline incision, like urologists, gynecologists, vascular surgeons, and also you know that there are a lot of ways of transverse incision from hepatobiliary, pancreatic, and upper GI surgery. The urologist also is involved in lobotomies and also a specimen extraction incision, also in colorectal, also in gynecology, also in urologic surgery, and all of them has in common that their wounds may have a bad consequence of incisional hernia, but also denervation in lateral incisional and lateral incisions, and also a pain. That's also a factor to be analyzed. And I will have the opportunity to join several surgeons from several specialties, thanks to the support of Medtronic. And we call ourselves pop surgeons because we like the progress on prevention of incisional hernias. And we have like a global aim of trying to obtain incisional hernia rates lower than 10%. That will be a big success, no? And these are the team. They are not all in this picture, but we join in several times, and from Belgium, Italy, from Spain, and also from Norway, and we join here not only general or colorectal surgeon, but also gynecologists, HPV, urologists, and vascular surgeon. So we have these 3 meetings. Before starting the pandemic, we have these 2 first in Madrid and Milan, and then we have a compulsory online meeting in April 2020, where we try to analyze several things. And we were discussing about how to reviewing the incision and the abdomen, how we can make recommendation for better incision, recommendation for better closure, and of course, recommendation to build evidence. So we divided our group in several teams, and this is what we have been working. We plan to publish this paper, trying to call the attention on not only in general surgeons in colorectal, but also in other specialties. And we have published this paper, and the first one of the teams working separately was this work from Cesare Stabilini, that he's going to talk about it. But we have also now here in Spain, we are working on data on urology, and we know that Frederick Berrevoet is now working on data of HPV surgery, and probably in the next year, during this 2022, we will have the opportunity to publish some evidence on urology and also in HPV surgery. I think that we need to bring this evidence, and this is what Cesare has done, working on colorectal, and he's going to tell us now what has he found after reviewing so many papers, so many articles about the incisions rate, the rate of incisional hernia in colorectal surgery. I'm going to stop sharing, and this is the thing we have found in the last 2 years. It has been a great opportunity for us to work together with, and also again, we have to thank a company, a private company, Medtronic, who has supported us, the meeting that joined us, but has not participated in any way in the papers that we are working in. Thank you again for giving me the opportunity to be here.
Okay, thank you very much. Thank you very much, Miguel. I'll go on without taking too much time. I think that Miguel has already outlined our aim. Our aim was to explore the incidence of incisional hernia after surgical access to the abdominal cavity to accomplish resection, extraction, or anastomosis of a bowel segment for colorectal benign and malignant disease. What was our purpose? Firstly, to synthesize the known evidence for incisional hernia in this field. And the second is to, because otherwise it was only a picture of the situation, we wanted to give a map of the empirical research that has already been done, but mostly to highlight what are the gaps. So we went for a particular type of analysis, which is the mapping review. It is a systematic search of a broad field, like colorectal surgery, in which we try to find the gaps in order to give direction for future research and to highlight in a friendly format. You will see a particular type of graph that you use in this type of review, and it was very useful for us, suggested by Manuel López Cano, who's always on the edge, on the cutting edge of this type of paper. For the mapping review, the method that we have used are the common search criteria, looking into database. We decided to include each study concerning the field of colorectal surgery, so randomized controlled trial, observational studies, and in particular studies coming from registries, and you will see the reason after. Enrolling at least 15 patients with an reported incisional hernia rate with at least 12 months of follow-up. All the type of surgery were allowed in the paper: open laparoscopic, single incision, and robotic. Primary resection, stoma reversal, or stoma closure were the other setting that we analyzed. We have to say that in case, since we wanted to give just a picture, we decided to take only the control arms of comparative studies on prevention without giving a look to the technique, to the results of the enhanced closure technique, such as mesh augmentation, small bites, and other variation of the techniques. And we decided, in case of case control studies, to use both arms, using one arm in the type of surgery that it belongs to. We found 91 studies. We decided to search the articles within the last 11 years. We found 91 studies at the end of the whole process, as you can see by the Prisma graph that you have on the right side of the slide, enrolling 6,473 incisional hernia after 100 and 1,000 different laparotomy. 11 randomized controlled trials were selected, 80 retrospective studies concerning 6 national registries, 24 case control, and 50 case series. Concerning open surgery, we didn't find astonishing stuff, but we were able to point exactly the number on of the incisional hernia. When we deal with midline laparotomy in colorectal surgery, we can expect a rate of incisional hernia which goes from 0.35 more 35% for randomized controlled trials on prevention, going to 0.04 for registry. This difference is important, and we will see later the reason behind it. We know also that whenever we go for radiological assessment, we will find a higher rate of incisional hernia as well. And this is again statistically significant in relation to clinical assessment. When we go for off-midline laparotomy, the data coming from randomized controlled trials, and we have to say that we have selected just randomized controlled trials, not dealing with prevention, and retrospective surgery is similar. When we compare midline and off-midline, we know that the incidence of incisional hernia is higher, of course, in midline laparotomies. For a factor that is very high, because it's 16% in case of a midline laparotomy and 2% in case of a non-midline laparotomy. Concerning laparoscopic surgery, it's difficult to define the correct number of incisional hernia rising in the trocar site axis, because we have only retrospective studies dealing with this type of problem. At least 2% of patients will develop this type of problem. So it's important to highlight this, because a preventive strategy on this subset of patient would need a lot of patients to define the exact number of and effectiveness of the strategy of prevention. Concerning SEALS, sorry, it's missing the name. Concerning SEALS, we have one RCT for retrospective studies. You can see it, and the rate of incisional hernia is 6%. We're not able to define whether SEALS was used single incision laparoscopic surgery, where the SEALS port was placed in the midline or off midline. So this number is probably mixed. Concerning laparoscopic surgery, midline extraction site and off midline extraction site, the results are quite clear. We know from randomized controlled trial that the risk for a midline extraction site is almost 10%, and lower in registries, 4%, at least half. For off midline extraction site, again, it's 4% and similar across all the type of studies that has been checked, so randomized controlled trial and retrospective studies. When we go to comparison of midline versus off midline extraction site, of course, we notice a higher presence of it's inverted, the number of incisional hernia when we deal with off midline and midline extraction site. There is a mistake. There's a double the risk of off midline incisional hernia rate. For this type of comparison, we decided also to compare incisional hernia proportion in laparotomy versus extraction site. Why? Because we noticed that the number of patients, the number of incisional hernia coming for a midline laparotomy could be similar to those coming from a midline extraction site. And it was quite clear. Whenever you use a midline axis, you will have a not different incisional hernia rate comparing midline laparotomy and a midline extraction site. The same for off midline laparotomy, and this is important. Stoma reversal incisional hernia is another topic which is very important. Despite being an off midline incision, usually we found that the rate of incisional hernia rises according to the type of studies, and in the single randomized controlled trial that we have found in the literature, which is the one run by Anil Bangu, it is the ROX trial, reporting a 20% incisional hernia rate in patients undergoing a reversal of an ostomy. while in registry is almost absent. When we perform a meta-regression, putting some factors as predictors of incisional hernia, we interestingly found that a randomized control trial focused on prevention has the highest risk of finding incisional hernia, as expected. I think that extraction site of midline could be a protective factor, that open midline is one of the biggest causative factor for incisional hernia, as well as stoma reversal. I told that we use the type of mapping review as highlighted in the methods, and it's quite interesting to see the number of patients enrolled in each type of study according to each type of laparotomy, of abdominal incision. The best evidence, as we can see, comes from trials enrolling almost 100 patients for open midline, 300 patients for stoma reversal, which is quite disturbing, as we're speaking a lot about evidence and quality of evidence, and these graphs show that the patient used and the accrual number in this field are very low. We don't know quite anything concerning open of midline incision, quite anything about port and single incision laparotomy. Very low are also the data of robotic surgery. So it's very sad to see that there is a big road ahead to be gone yet. We know that incisional hernia detection technique arises with the type of follow-up that is done. This evidence coming maybe mainly from retrospective series. We have just one trial on prevention assessing the radiological follow-up and the radiological incidence of incisional hernia, which is, I think, quite disturbing as data. As well as disturbing is the mean length of follow-up for good quality studies, which is approaching at least at maximum 24 months, while for registries we have biggest number, as you can see. So a lot has to be done still. The limitation of our work is that, of course, the data have an high heterogeneity on a statistical point and on the conceptual point, so they should be taken with caution. There is a total lack of a description of subgroup of patient according to diagnosis, benign or malignant, diverticulitis, emergency, risk factor for incisional hernia, totally lacking in all the papers that we have checked. There is a lack of information on the closure technique out of the studies dealing with prevention, and the quality of the follow-up is generally, as you saw by the mapping review, very low. Low for length and for the type of technique. So the data are not so reliable. Maybe with longer follow-up and better diagnosis, incisional hernia rate could be rise again. I have highlighted some point of discussion that we can discuss afterwards. The proportion of patients reporting incisional hernia is clearly high after midline access, and it was expected, as already highlighted in other type of studies. The reason behind this is perturbation of the central tendons, the linea alba of the abdominal wall. In this light, non-midline access should be preferred because it's not influenced by lateral traction, neither by problems such as tension or atrophy. Despite this, there are no data on how to close effectively an offline midline laparotomy, despite a clear guideline recommendation coming from the guideline on abdominal closure produced by EHS and now recently updated. You will see the publication very soon. Another point of discussion is laparoscopy. Should be preferred to open, not maybe because of the low rate of trocar site, but whenever enough midline extraction is used for the extraction of the colic specimen. We found that the extraction side had the similar risk of failure to a formal midline laparotomy. So again, the proof that whenever you perturbate the central tendon, the linea alba, you will encounter sooner or later on an incisional hernia. Another paradox is the stoma reversal side. They are an off midline incision, but they suffer of a higher incidence of incisional rate. Hernia rate. This is because the higher risk of local infection, or maybe because they are iatrogenic hernias in their nature, and maybe this could contribute to a higher risk of incisional hernia whenever they're not closed with the prosthesis, with the mesh. And then two questions. Incisional hernia proportion rise in relation to quality and main objective of the study. So we know that a randomized controlled trial designed for prevention are useful to detect a higher number of incisional hernia. But is it relevant? Because we know that registry, even if underestimated the real incidence of incisional hernia, are able to show the true number of patients that are seeking for a treatment and receiving maybe an incisional hernia repair. Second question, colorectal surgery is a high risk for incisional hernia, as we have already shown, in particular when a midline incision is adopted. So why do surgeons are still not using small bite and mesh augmentation to prevent the occurrence of this problem? Okay, thank you.
Thank you, Cesare. Actually, we are collapsed because you almost answered all questions of us, but we will find something to ask. I will present slides here. You can give some brief answers because mostly you mentioned in the presentation. So our first question is the detection of the incision hernia. You know, mostly we do surgery for the colorectal patient as for the cancer, and we follow for their primary outcomes for the survival and recurrence. So should we check the incisions after the colorectal surgery? If so, and when and how? And you see our Twitter. We ask in this question in the Twitter, and we have the answers here. And we ask you to review this reply.
But to me, I think that the situation is clear. I mean, if you're undergoing a colic resection for cancer, of course you will be followed by with a CT scan strategy. And I think that the time point that are obliged by the cancer follow-up are good for checking incisional hernia. But the relevance of incisional hernia is in the moment in which it becomes symptomatic. People, because if you detect it, there are limits to the treatment. Maybe the patient is undergoing chemotherapy, radiotherapy is not the right moment to operate on it. So it's more important to have the CT scan checked at the end of the treatment. And if I can say, it's better to check it before the closure of the abdomen and use an enhanced closure technique such as small bite or mesh in order to avoid it, because we don't we don't prevent just incisional hernia, but also fascial dehiscence, which is a more dramatic problem that can lead a patient to death. After performing a good intervention on the colon, you have your patient dead when he or she has a problem and risk factors. So prevention is more important.
Alex, I hand over the talk to you.
I want to add something here. So a comment and a question that also Andrew Dubu asked in the chat, because we see that many studies that study trocar site hernias report a very low incidence, but when you look with studies that ultrasound with sonography in port site studies for bariatric surgery, it is very high. So we can assume that a big part of these hernias go undetected, which can mean two things, or it means two things. First, it's we don't look for them, so we probably have to look more. But the second part is that probably they're asymptomatic. So do they matter? And the second one, like you said, like the survival rates that are measured. What would be the point to measure also in cancer patients, not only regarding to hernia surgery, but also in cancer, colorectal cancer, to measure for incisional hernia?
Can I say something?
Yes, please.
They are both quite interesting question. Of course, it's the question. Well, the first one is about how can how can we detect a hernia, and how is it important, or if this will become symptomatic after all. And that's, you know, and I think it's a question that has we haven't got the answer. We don't know if a hernia that is only detected by imaging is important or not. We don't know yet that answer, but we know from the history the story of an incisional hernia, that most of them becomes bigger and bigger and become finally symptomatic. Probably it would be quite interesting to also to make a trial of poorly symptomatic incisional hernias and to make a watchful waiting instead of operating from the very beginning. That could be also a very good question to be answered, you know. But we have seen in the inguinal hernia that most of the asymptomatic finally become symptomatic and had to be operated. So probably that's going to be also the story of incisional hernias, but we don't know, you know, it's only a hypothesis, no? And it is better to operate an incisional hernia when it is not big, when it is simple, can even be made with a more simple laparoscopic approach that to become a complex. We have seen during this pandemic a sad story of incisional hernias that were simple, that were grade, that were W2, that were less than 10 centimeters. And now in the waiting list, when we see this patient in the operating list after 1 year waiting, more than 1 year waiting, they are now in 12, 14, or even 15 centimeters wide. So now we are in fact reviewing all our incisional hernias that are being operated after the pandemic to check, because if there's some worsening on the incisional hernia after such a long time waiting for the operation. So we don't know, you know, if it's important enough, if it can, but what is important what is important is to remark the importance that we need to reduce as much as possible the incisional hernia rate in any, in any incision, no? Even in trocar, even in a small extraction site incision, we need to work and to make more evidence about what's the best way to close these trocars and to close these extraction site incisions and all that. That's quite important, I think.
Yeah, and Debo says that most trocar site hernias remain undetected. So do they matter? And we have been doing laparoscopic surgery for decades, but in clinical practice we don't see a lot of trocar site hernias. So I also include our second question to this discussion, as because of the nature of the colorectal surgery, due to the poor 5-year survival rates of these patients, do we really neglect these patients' incisional hernia, or we postpone to repair them because of they don't have long survival rates?
But
is it a habit?
Maybe if I have to say something, we're not neglecting them. We're postponing the treatment. In this moment, it's not the case because of COVID, but in the past, we were postponing the treatment and we were waiting for them to heal from their cancer. So they're not neglected, I think. It's difficult for them to arrive to the table because sometimes they're not fit for surgery. And this is an important stuff. Other times they don't bother about the problem of incisional hernia. It's more a problem of us. We don't know. We cannot decide a priori whether a patient will have an incisional hernia. That's why it's wise to adopt a better closure technique. But we don't know which patient will benefit of that, because most of the patient will develop small hernias, asymptomatic, and maybe we won't try to operate on them, and they won't ask us to deal with their problem.
Okay.
And I think it's a very nice comment, because here it fits very well with discussion going on in the chat between Barbara Ist and Adri Dibo about the risk of operating on incisional hernias that are small and asymptomatic, and not taking into consideration the patient outcomes, patient-reported outcomes. If perhaps we are adding comorbidity by operating into a patient at a state that perhaps doesn't need to. I think that is very interesting.
Yes, we really don't know. We don't know the answer. I think that we don't have enough studies that can answer that. But that's an interesting hypothesis, and should be taken in consideration. Of course, I don't know if what is better. If probably an old man with a very small asymptomatic and the risk of complication is low, probably you don't even need to operate him at all. No, I completely agree. No, so but we know that also some incisional hernia becomes bigger and bigger and very symptomatic. No, so but I think that's the natural course of the disease, or at least in what I see in my clinic. No, but probably because I don't see the patient that has an asymptomatic hernia that is only detected by CT scan. No, probably that's the reason. No, but of course we don't have that answer. No, but it's something very quite interesting to take into account.
Perhaps we need more studies or outcomes measured regarding the subjective quality of life of the patients, what they think.
For sure. Yeah. Even I think that it was also asked before that some some kind of estimation of the quality of a colorectal cancer program should be not only survival but also incisional hernia or symptomatology related to incisional hernia. No, of course that's I think that's should be in consideration as a patient-reported outcomes. Of course, the incisional hernia.
Alex, you go, please.
Yes. I think we had covered this question, and then we go to the third one. Like the current data that you were able to gather through this review that you did. What does it say on prevention on incisional hernia after laparotomy, after stoma reversal, extraction site, and after cells? What can we come to a suggestion on this? Can
I say something?
Yes, please.
Okay. We know from the guidelines that midline laparotomies and in high-risk patients, we could the prevention incisional hernia with enhanced closure techniques and with mesh prevention. After guidelines publications, several articles and RCTs were published on this topic. And we know that mesh prevention is useful, safe, and recommended for midline incision, also in emergency setting and in high-risk patients, such as in obesity patients and in high risk of incisional hernia development patients. After some stoma reversal is useful and recommended also the use of mesh prevention. But we don't know exactly what we should do in single incision laparoscopy and in extraction site, because we have no enough data published in literature. And we are also seeking for what kind of mesh exactly use for prevention and in what kind of space to put the mesh for prevention. And I think that more data should be produced for do an exact recommendation on these topics.
So
thank you.
Question 4.
Now let's go to question 4. Yeah. This is the result of the warm-up survey that we did on Twitter. If we do of the people that were asked if they do mesh reinforcement for stoma reversal, and the majority of them said no. Only 30% said yes, and 13% were on the fence. So they're not really, they could be per se to either way. And I'm curious about the 9% that has no idea if they do it or not. What would you say to here? But no, I think that we covered this question with Sara on the comments. So I think
surgeons are worried about the use of mesh in stoma reversal field because of maybe the fear of an augmented of surgical site infections, but we know from recent meta-analysis published that there are no increasing of surgical site infection in the use of a mesh as prevention after stoma reversal, with a lower risk of incisional hernia after stoma closure. And we know also that surgeons are not so useful with the use of mesh in prevention overall, from a survey published by Fisher last year, maybe.
Yes, and I think that gives us a good forward to the next question that also has to do with guidelines. This time and guidelines implementation, this time with the guidelines of the European Hernia Society regarding the abdominal wall closure. Hakan, can you move to the next question?
Yes.
And we know that the EHS recommends the use of small bites in abdominal wall closure, but what does the data of this review suggest? Do they do it, the colorectal surgeons?
I think that the field of colorectal surgery is the first that should be aware of this technique. The small bites is very effective in reducing the problem. What is important, as already highlighted, is the type of patient on which you're using this strategy and all the enhanced closure techniques. We still don't have a good tool to define whether the patient is so high risk to need a mesh or so low risk to be closed with the small bite techniques. We have the hernia score produced by JP Fisher that would help us in deciding which type of patient should be given this type of strategy. We're not able to define which strategy should be given to them. We know that some patients that are at high risk, small bites was recommended as a strong recommendation. I don't want to spoil anything about the updated guidelines, which are very nice and produced by Eva Dierenberg and Philip Muisum, and we have recently finished to publish them, so you will see them out and you will decide. Things are changing, and good studies are needed to define the role of each enhanced closure technique, because with the new way of grading evidence, it's not obvious that a single randomized controlled trial can be effective in judging whether or not the technique should be used to close effectively the abdominal wall. So I'm bouncing back the question: should be small bites used, and when should small bites be used?
So Cesare, Andrew asked, most surgeons know, I know, say their incisional hernia rate lower than the small bites, small trial rates. So how we convince them that their rates are high? How we convince the surgeons, colorectal surgeons or general surgeons to
can I say a joke? The biggest lies in life are told by the fishermen after they come from a big fish and talking about the big fish they lost after the war, because they always say that they won. And I would say even after surgery, because we always say that we have zero complications, zero recurrence. So we're a liar. I think
the general condition.
Yeah, it's difficult. Probably, as Barbara is suggesting, probably if you are obliged to know your data, no. If someone is able, can put your data on the computer, on your in your phone or something to check what's your incisional hernia rate, is the only way. Probably. But there's a lot of time, at least in Spain, for that to come. No, it's a long way to go. But now I think that we need to we need to promote the necessity to better close the abdomen in colorectal, but not only colorectal. I think in vascular, in gynecology, urology, and in all specialties that are dealing with the abdomen. No, I think it's quite important to and that's the reason we are here. No, and EHS is now here, and we are now joining at 8, almost 9 p.m. Almost time to dinner in Spain. Almost, not yet, almost. And we are now discussing about this because we think that it is important, and we need to spread the message.
I totally agree, and I say that a very important message would be, if the way I understand the data in the study is that right now we're not at the point where we suggesting to surgeons that they should do small bites, but what was seen, and correct me if I'm wrong, is that in most of the studies that you saw, the closure way was not even mentioned. So we're not really, it was not a significant factor that they didn't consider it significant enough to document it, only in studies where this was the point. So the first point is to convince them that it's significant, and then how?
Alexis, coming back from my joke about lies, we decided to conduct a survey, and maybe Sara will tell some result of this survey and the technique we adopted to find the real truth in the answers.
We used the surgery residents across Italy, such inside men, to describe how the abdominal wall incision are closed by our mentor in Italy. And a lot of residents don't know what small bites are and what prevention of incisional hernia is. So we can imagine if our mentors give us the possibility of perform small bites at the end of long procedures, we could perform correctly small bites and decrease the incisional hernia rates in our patients. Maybe this is a possible answer for the future.
Yeah.
So we were able to define truly the fact that people are not using what is recommended in guideline closure. They know PDS, the slowly resorbable suture, but they're not convinced.
Actually, probably we need to set the randomized controlled trials groups, that which outcomes is important to make decision. Actually, you intended to do with this publication. I'm in a group that we are trying to define the core outcome sets for the inguinal hernias. So this way can be used for the incision hernia prevention, as did for ventral hernias before. Last question.
Please, Cesare.
Yeah, I finished.
We see that, and to go to the next question, that the surgeon is a very high risk factor for incisional hernia. And what would be the recommendation to prevent it after the Caesar hernia? Would it be to educate themselves first about the prevention?
Incisional hernia, in studies we analyzed for our paper, is often an unexpected outcome after colorectal surgery. But if we can plan in what kind of patients incisional hernia is a high risk for the future and in the follow-up of the patient, maybe we can plan the correct type of suture for closure, and maybe if the mesh augmentation is required for this patient, and incisional hernia is planned for decrease the rate of happen.
And an interesting comment from Andrew Debo, so that would be to establish bundles of care around closure. Would that be a solution?
Yes, I think that what is said by Professor Jekyll is always right. Abdominal closure is no coffee time, and it's a moment in which maybe I think residents, trained residents, should be involved. They're eager to work. They're eager to work properly. They can make the difference. And after waiting maybe during a long procedure, they may be happy to change the outcomes of the patient by performing their procedure. And on the other side, it's more important to raise awareness among consultants that this problem is important, because whenever you have a fascial dehiscence, you're risking the patient's life. And whenever you use an USP1 loop, you're on a high-risk patient, you're maybe having this type of risk. And it's important to do a correct closure with a good idea. I'm against the concept of abdominal closure team, because every surgeon should be able to close an abdomen properly, as well as performing a laparoscopic suture. But maybe if the first surgeon is tired and there are other surgeons in the team that are eager and wants to do, better let them do the enhanced closure technique. It's better for the patient and better for everyone.
Yeah, but I think that we are not talking in the desert, because, by example, in my country now, colorectal surgeons has edited the second edition, has just published the second edition of a colorectal book about every part of colorectal surgery, and we have been invited to write a chapter on how to open and how to close the abdomen in colorectal surgery, and with videos included, with all, and interestingly, as Andrew Debo has also commented, interestingly, is in the same chapter of surgical site infection prevention. So probably Andrew is, I think he's also right there, that probably we could make something similar to that, to try to convince surgeons that making something different in a similar way as the surgical site infection. There are so many things that can have this risk factor, but this is even easier than surgical site infection, because we are seeing that we can make it just better with one technique. So probably one technique is enough to reduce the incisional hernia rate, or maybe make both, small bites and mesh prevention.
Yeah, and I think if I also understand the comments from Barbara, well, another reason for the low awareness of incisional hernia in colorectal surgeons is that they are rarely the ones that have to repair the work afterwards. This falls down to abdominal wall surgeons, and as it is at the moment, abdominal wall surgeons, people that work for the abdominal wall, are the ones that are most aware of prevention. So the
Yes,
ones that handle the problem are the ones more agile in preventing it.
Alexis, I think that we have two problems. First, we don't know the exact patient at risk of incisional hernia. With this, we have just one model, which is the hernia score, as I've already said. We don't have long-term data on mesh augmentation, and Miguel Angel Garcia-Urena is one of the few that has provided this type of data. We are concerned about the risk of implanting on each patient a mesh. We are in the middle of a storm against the mesh. It's not our fault, but we don't know. We know that whenever you implant a mesh in the onlay position, you have a higher risk of seroma. This means that you will have surgical site occurrences in a lot of patients. You won't have surgical site infection or surgical site occurrence requiring procedural intervention, but you will have adverse event when you're placing a mesh in a patient. Not all the surgeons are able to place a mesh behind the muscle, and we know that whenever you enter that plane, you lose the good plane for an incisional hernia repair. So our questions are so many that it's difficult to say that they are solved by 2 or 3 trials that are already performed. We need to know the real role of small bites and then decide the role of mesh augmentation.
Okay, we're on the time.
And regarding the question of the, you know, the mesh material, no, the composition of the mesh, this is quite interesting, because now we are, you know, when all these studies started on mesh prevention, I think large pore polypropylene was the ideal one to use, and has been, most of the studies have been done with polypropylene. But we now have long-term absorbable meshes that can make the same work as permanent synthetics, and it can completely absorb. So probably this could be also a matter of future discussion, immediate discussion, but because these long-term absorbable meshes can make a good job while you know, preventing incisional hernia. But we don't know, you know, it's, and probably we even need even more long-term absorbable meshes that probably even 1 year is not enough, or 1 year and a half. So it's also an interesting thing to discuss about, of course. And also we can also discuss about contamination of uses of meshes in prevention. That could be also something to discuss about.
No, but the results are really strange, because if you see the ROX trial, they used biological meshes, and the biological meshes are almost not performing well in other planes. So it's mad what is going outside. There is so much heterogeneity that we have to take in account that it's difficult to make a final recommendation.
What do you suggest as a solution to this heterogeneity? Is the study design that we are currently making at fault? What would we need to be able to go forward?
You saw a mapping review. There is a lot to be done. I mean, a lot of studies, randomized controlled studies. We have to know the basis, and in this moment we have difficulty in deciding what are the basis. So we have to work harder.
We don't even know if small bites is better than MS, by example, no?
Yes.
There's some trials going on this way, but probably we need larger RCTs, multi-center. Now we have these tools that we should be starting to use, no? That we can connect now as ever before, and that's also a good opportunity and open, you know, these possibilities to make very big trials with a lot of hospitals involved. Something similar to what has been done with the COVID and COVID surge or something like that. That would be great, you know, to have many, you know, collaborative projects that will, and that can help to reduce heterogeneity. Sorry, in this studies.
Miguel, in this moment, a lot of surgeons are using mesh and small bites together. It's another arm of the
sure. Why not use both? But we need a lot of patients to include. You know, probably we need more than 500 in each arm to, you know, to be sure that something is better than the other, no? Yeah. Or are better together.
Okay, it's time. We have come to end of this session. Thank you very much for you joining and contributing to our session. It is a great paper. Thank you again, Alex.
Thank you, everybody, for a very nice discussion. I think we could have discussed this another hour.
Yes.
Yeah.
For sure. Thanks, Open Hernia Society again, and Hakan for this important effort you are doing. And I think these discussions are always interesting and constructive, and always an opportunity to learn.
I also thank to the audience for their also great contributions as well. Thank you, and have a nice evening all.
Have a nice evening.
Bye.
Nice evening.
Bye.
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 Bye, Sara.